Great. And so today I'm presenting on behalf of the Pwani Research Center, which we've recently rebranded, which is in Mombasa, about our implementation science studies in partnership with Mombasa County. And so this is on behalf of our group, as well as the University of Nairobi, Kenyatta National Hospital, and Mombasa County Department of Health. There we go. So the objective, very brief introduction to implementation science, and then I'm going to talk about 4 of our almost completed or ongoing studies that we have had out of the Pwani Research Center. So I think many of you know, and much of what we do kind of in global health is looking at implementation science. So trying to understand that there are evidence-based interventions that work, and we're trying to figure out how best to implement these implementation strategies. So how do we get evidence-based practices, interventions, or policies into routine healthcare and public health practice? And so this is the no-do gap that we talked about. And so Professor McClelland, who gave the introductions earlier, for almost 10 years ago, met with Mombasa County to discuss possible implementation science studies with Mombasa County. Out of these meetings and a few proposals later, the FP-HIV study was born. In 2016 to 2017, I helped launch the FP-HIV study, which was the impetus for my Career Development Award, which is CCSI, which I'll be presenting that as well. Then FP-HIV Scale, which is now in its 2nd year, expands upon the results of FP-HIV. And then we have the FSB study, which was further strengthened collaborations with Coast General Hospital as well in Mombasa. And then we have more future IS proposals coming down the pipeline. So our FP-HIV study, so all of these have been in collaboration with Mombasa County, University of Nairobi, Kenyatta National Hospital. Scott was the PI on this, but a number of us trainees were on this, as well as UW collaborators. And so, as many of you know, a high and increasing proportion of African women utilize family planning services, or FP. And the National AIDS and STD Control Program strongly recommends HIV testing and family planning clinics. It makes sense that family planning clinics are places where sexually active individuals would go to seek contraceptive care, but would also be at risk for acquiring HIV. So in 2008, the Family Planning Register was updated to include columns for HIV counseling and HIV testing, but our preliminary data suggested that HIV testing in FP clinics is low. So the aim 1 of this study was to conduct a cluster randomized trial comparing the effect of SIA approach, which I'll get into, versus usual procedures on rates of HIV testing in first-time attendees at 12 intervention and 12 control clinics in Mombasa County, Kenya. So what is SIA? You'll see SIA a decent amount, so I'm only going to describe it once, but it's the Systems Analysis and Improvement Approach. It was adapted for healthcare by Kenny Schur, who many of you know here at the University of Washington. And it involves 5 steps. The first step is a cascade analysis tool where you visualize a cascade. So in this setting, it's the HIV counseling and testing cascade in family planning clinics. You use actual data, you plug it into the system, or into an Excel sheet that we create, and it helps answer the question, how are we doing with our HIV counseling and testing, and where are the biggest drop-offs? There's an optimization function that we put into the cascade analysis tool that allows you to see if we were to work on this one step in the cascade, how would that impact and what impact would that have on the rest of the outcomes in the cascade. The next step is to do sequential process flow mapping, where you start at when a client enters the family planning clinic to when they exit, and you look at how do clients currently flow through our clinic. So where do they go? How long do they wait? Then, when do they stay in the waiting bay? When do they go to pharmacy or lab to see the clinician? And this is to see the whole clinic as a system and to try and identify where there might be modifiable bottlenecks. The next step is kind of those plan, do, study, act cycles, but we identify, define, and implement some sort of workflow modification or a micro intervention, as we call it, trying to figure out how can we make changes to make our system more efficient to increase HIV counseling and HIV testing. And these micro interventions are kind of developed and implemented by frontline staff who are in the FP clinic, because they know their system the best. Then we look at how well does our change work, and should we adapt this microintervention because it kind of worked, but we think we could do better? Should we adopt it because that microintervention worked and we see data to suggest that it works? Or should we abandon it? It didn't work, we should move on. And then we repeat this analysis and improvement cycle. So these are the results after 12 months in this cluster randomized trial. This is looking at HIV counseling. So intervention clinics are in green and control clinics are in blue. And you can see that from baseline data through Q4, that the intervention clinics did much better at percentage of new clients who were counseled for HIV testing. So, you know, for some reason, by chance, those in intervention clinics started at a much lower baseline. But ultimately, there was a strong association between those clinics who were implementing SIA and more new clients who are being counseled for HIV testing. When we look at HIV testing, so again, same green and blue, again, the intervention clinics started at a much lower baseline, but over the course of the 4 quarters of this study, the intervention clinics had consistently and sustained more HIV testing than control clinics. You can imagine that this is still, there's still room for improvement, but still exciting to see. And I will also say, we focused on new clients. Many clients will come back repeatedly if they're on depot, you know, they come back every 3 months. But really, the guidelines suggest that the first time that you're seeking family planning services, you should at least have an HIV test done. So that's why this is focusing on new FP clients. In terms of our yield of new positive HIV diagnoses, it was low, but still argues that it is still an important place to be performing HIV testing. So aim 2 was to determine whether the SIA training results in a lasting effect. So in aim 1, our study staff really facilitated, collected the data, and worked directly with the FP clinics to develop and support them in their micro interventions. Aim 2, we wanted to see what if we transition the kind of facilitation of SIA to our Mombasa County Department of Health staff. So these are reproductive health or AIDS coordinators who could support as part of their ongoing duties this project. And so this is a similar graph. Here is control is orange and intervention is blue. I will say this happened during both COVID as well as the healthcare worker go slow and strike, which impacted kind of healthcare delivery. And you will see this come up again in 2 studies. But you can see that for HIV counseling, our intervention clinics maintained a strong, high prevalence of HIV counseling, even with the disruptions to healthcare delivery. And similarly with HIV testing, that our intervention clinics in blue, where SIA was associated with much higher rates of HIV testing and intervention versus control clinics. You can see that our kind of during COVID, that the numbers of clients were greatly reduced because of all of the disruptions. So again, we felt like even when SIA was kind of transitioned with minimal support from our research staff, that it was still productive. So then aim 3 was to look at the incremental cost and budget impact of applying SIA versus standard of care. Another one of our Scott's trainees worked on this, but for an annual program of 36,000 HIV tests, it was less than $100,000 US with an average cost of $2.55 per new client. This is, much of the costs were personnel as well as HIV tests. And that if there were no program outputs under an MOH scenario, that the cost per new HIV client being served drops to $1.30. So we felt like in general, this SIA is still a low cost and also flexible implementation strategy. So taking those results, we then scaled up and to the FP-HIV scale study with similar collaborators, and some of whom are still in the room. We also have a scientific advisory board with members of Mombasa County, the WHO, Pwani County, the neighboring county next to Mombasa County, and then tentatively with NASCOP MOH. And so the goal of this grant is to scale up SIA, again with implementation solely by Mombasa County Department of Health staff. So our aim 1 is going to look similar, but in a cluster randomized trial. And while in the original FP-HIV study, we looked at just HIV counseling and testing, a lot of our feedback from our collaborators was we have to do more. We need to look at both HIV counseling and testing, but we need to look at linkage to care for those who are living with HIV, as well as screening and linkage to PrEP. And so expanding out FP-HIV to include those linkages. And we focused again on those new FP clients, but also given the high burden of HIV in adolescent girls and young women, we have a particular focus on that population. And then a similar incremental cost and budget impact. So where we are now, so this is kind of the flow diagram. Client comes in, they're counseled for HIV testing. If they don't require testing and their status is known and they're linked to care, then we don't need to do anything. But those who know their HIV status who are not linked to care, the FP clinic staff help link them to comprehensive HIV care. For those who require HIV testing because their status is not known, for those who are negative, they'll be screened for HIV or for PrEP eligibility. And then if eligible, then the staff will help link them to services. And then for those who test positive, they will also be linked to comprehensive HIV care. So kind of the wraparound HIV treatment and prevention services. So in order to do this work, as many of you know, there is a PrEP registry in Kenya, there is an HTS or HIV testing and counseling, there's a family planning register, there's also a comprehensive care HIV register, and while people living with HIV generally have a unique client number, that's being rolled out, but at this time, there's not a clear way to link individuals across multiple registers. And while KMH has an electronic medical record, many other systems do not. And so we received approval to modify the MOH 512, which is the family planning register, for a research record only, but to add in columns to try and have a comprehensive data system for all of the family planning clinic in our studies. So this is what the FP register looks like. It has kind of basic demographics, and I'll zoom in a little bit. It has the contraceptives dispensed. We added on this page this unique client number. As the country is hopefully rolling out unique client numbers for all Kenyans, hopefully this could be a way to, in the future, to link. So we added that. This client number is the client number that's given by that individual FP clinic. And then this is the right side of this big book, and it has more of the commodities dispensed. It has what the HIV counseling and testing, but we have added the eligible to be tested with the move towards kind of Kenya's targeted testing algorithms. Not all individuals would necessarily be eligible for testing, so we wanted to capture that. And then this whole area on PrEP has been added, so they were screened for PrEP, eligible for PrEP, and linked to PrEP, as well as for those who are living with HIV, linked to HIV care. We rolled this out in January 2023 with our awesome Pwani Research Center staff and trained 169 of around 195 facilities, family planning clinic facilities in Mombasa County, where we trained them, and then we distributed 183 facilities, and this was over a week's time period, which was a really incredible effort and great collaboration with the health records officer in Mombasa and the sub-counties. It was really incredible. And then we were able to actually get some preliminary data about what does this look like for 3 months in our research record. So ultimately there were 186 clinics. We found that some clinics either didn't see family planning clients, et cetera. And collecting data from earlier this year, it was 29,000 total client visits, with about 41% of these are for adolescent girls and young women. And first visit was also quite high for AGYWs. And new clients, about a third of these. So I will say that there is, this is a ton of data, and so the discrepancies that are listed here are the discrepancies between like numbers adding up for those columns out of what they should be. But in general, the percentages are quite low for the amount of data. And this data was abstracted by our amazing staff. We have a system that we do this. We take images of register pages covering names and phone numbers, identifiable information, and then abstracting the data. But you can see out of almost 9,400 new FP clients and almost 12,000 adolescent girls and young women, many of them were counseled for HIV testing, but around a quarter were eligible to be tested. And this is the HIV testing screening tool that we used, which is in combination with Pwani, which is the program, PEPFAR USAID program, which Patrick Oyaro, who was here as an IARTP student when I was the IARTP tutor, was running Pwani. So we met with him to understand what are they using for kind of their information for screening. And so this was distributed with the registers when we distributed them, so we're starting from the same place. Then looking at those FP clients, how many were tested? So about a third, but slightly more in adolescent girls and young women. There was quite a high yield of new HIV diagnoses, so 3% and up to 6% in AGYWs, with some who were already known to be living with HIV. And I will say, the missingness of the data it varies, but kind of in that 10 to 20% where the columns were just not filled out. Then looking at screening for PrEP and eligibility for PrEP. So again, these numbers gets a little bit tricky because screened for PrEP should be those who we know are not living with HIV. So our screening NA should really be those who are living with HIV, and we know that that number was actually much lower. So there was some issues with not screened versus screening NA, but about a third of clients were screened for PrEP, and 14 to 20% were eligible. We used and distributed this tool as well, the rapid assessment screening tool, which is what the Mombasa County was using at the time as well, to understand if they're eligible for PrEP. So this was also distributed. And then looking at linked to PrEP, upwards of 2/3 of AGYWs who were eligible for PrEP were linked to PrEP, and then about a third of new FP clients. And then linked to care, I think there's always room for improvement, but a decent number of AGYWs had not been linked to PrEP. And I will say that, not been linked to HIV care. And this is pre-intervention. This is just trying to understand the baseline with our new tool. What does the landscape look like in Mombasa County? And so following this, we trained our reproductive health coordinators, the STI/AIDS coordinators, as well as the continuous quality improvement team and the health records officers in SIA. We then used that data that I had just shown to randomize clinics, and we selected 80 clinics, so 40 to be intervention and 40 to control. And then we did a kind of first SIA implementer visit to starting in August to start the study. Following, we did disseminate the results that I had just presented to our collaborators, as well as did kind of a register retraining just to kind of refresh everyone's memory on how to fill out the record prior to the start of the study. So that was a lot. So that's still ongoing. We're just finishing up We're going to start collecting outcomes data, which will be collected quarterly for all of those outcomes that we talked about. Now I'm going to switch gears a little bit, but now we're talking about CCS-SIA, which is was my K, which is just finishing up. Again, you'll see a lot of the same names here, and it will sound familiar. So while FP-HIV and FP-HIV scale, we're focusing on integrating HIV treatment and prevention into family planning clinics. CCS-SIA was focused on trying to improve integration of cervical cancer screening into FP clinics. So the aim one of this study was to describe the cervical cancer screening care cascade. So from those female clients who are potentially eligible for cervical cancer screening up through follow-up if you have a positive or suspicious screen. And then understanding kind of correlates of failure to screen for cervical cancer in these FP clinics, in Mombasa County. So these are the results of just like that landscape analysis. We visited and looked at 70 FP clinics, and CCS-SIA was running just for shortly after the start of FP-HIV. It was about a year offset. So this grant is just now running down, but so that's kind of the timeline. So of 70 clinics, we looked at, did the managers report that they did any cervical cancer screening? And then we looked at over a 15-month period, did we see any documentation in the FP register that they did do any cervical cancer screening? And on the original MOH 512 FP register, in addition to those columns for HIV counseling and testing, there are also columns for cervical cancer screening and result. And so out of those 70 clinics, 38, their managers said that they reported, or they did cervical cancer screening. But over 15 months, 22 of them, we actually captured any screening. Pretty even distribution between kind of urban and not urban. Many more private clinics than public, kind of 4 to 5 clinicians, so kind of to get an idea of the size of these FP clinics. Top 3 challenges for cervical cancer screening were lack of supplies, lack of training, and then clients refusing screening. And then how much of care is kind of given in, particularly in Mombasa County. Public and private facilities receive commodities, family planning commodities from the county free of charge. Private facilities might charge a convenience fee for either shorter wait times or because they're open 24 hours a day. And so we wanted to also capture if cervical cancer screening was provided at no cost. And so those clinics who did capture or at least documented any screening were more likely that cervical cancer screening was free for clients. You can also see that there was a range in kind of how many clients were actually trained to perform cervical cancer screening. To get a sense of kind of management structure and organization, we asked about management meetings, if they were being held, and then to understand kind of both visual privacy, as in a woman could have cervical cancer screening done with that, that was private, both visually as well as nobody could overhear. And that is, 3/4 of clinics had both complete visual and auditory privacy. So then looking at those clinics who said that they performed cervical cancer screening, you can see that in order to do VIA or visual inspection with acetic acid, you need a speculum to visualize the cervix, you need a light source, you need acetic acid, which is vinegar, and cotton swabs to apply to the cervix. And so you can see that acetic acid was a commodity that was frequently, or not readily available in upwards of 1/4 of clinics, but speculums still occasionally out of stock. So then looking at those clinics, so the correlates of screening, and these are when the clinic managers said they did cervical cancer screening, you can see that larger clinics were more likely to report that they screened public facilities as compared to non-public. And it makes sense that if you have at least one provider trained to perform cervical cancer screening, you're more likely to do it. And the results were similar when looking at those those clinics who we actually saw documentation of screening. Again, public facilities performed better, as well as having at least one provider trained. So we had originally had this grant, or I had this plan to kind of try to map the whole cervical cancer care cascade. However, as we talked about with FP-HIV scale, there is no consistent client ID, so it's very challenging to track individual women over time in the same register. And we only captured register pages when any screening occurred, because we were looking at thousands of entries. And so we don't really have a denominator. So what I'm going to present now is not prevalence of screening, but it's, or what I have presented, but it's visits when screening occurred. So our aim too was to do a cluster to test SIA, which you've heard of already, and whether it increases cervical cancer screening compared to usual procedures in 20 FP clinics. So we launched this in January of 2020. It was initially going to be for 12 months, but then, as we all know, COVID happened, as well as the healthcare worker go slow and strike. So we extended the randomized clinical trial by an additional 6 months. And so I'm presenting the data for the completed 18-month cluster randomized trial. We assessed and visited 87 clinics, or tried to visit. Ultimately, the 70 are the data that I had showed previously, and then we selected 10 to be randomized to intervention clinics, or to the intervention arm, and 10 to the control. I will say some of our intervention clinics were intermittently closed for many of them because of COVID and healthcare worker strikes. So this graph will look similar to the data presented earlier for that sustainability arm. And I should mention that Jess Long, who was a postdoc here, led the FP HIV sustainability arm. And this is her kind of graphic. But here you can see that in blue now is control, green is intervention. This is looking at Q1 through the Q6, and this is looking at the percent of eligible family planning clients who were screened for cervical cancer. So we started off really strong in the intervention clinics. COVID hit. You can see that this is looking at these SIA cycles, which are, we did them as monthly cycles. So you can see around when COVID hit, we had nothing, most things shut down. Not a whole lot was happening. We then had the healthcare worker go slow and strike, where we kind of lost, cervical cancer screening was not kind of top of priority. You can also see that around this time, kind of the number of clients was a lot lower as well. And then ultimately things rebounded. Our intent to treat analysis was going to be just looking at Q4. But given all of the disruptions to healthcare delivery during the study, we also looked at overall. So from January, from the start to the end, SIA was associated with a higher prevalence of visits where cervical cancer screening was performed. So the results for Q5 and Q6 were not as exciting. But that's what happens. Okay, and then aim 3 was looking at the cost and budget impact of SIA for increasing cervical cancer screening. That we've collected the data, and the analysis is in progress. And I will say that Brenda Oyara, who was a current MPH student, is embedding her dissertation. She's an AKU student through the AKU funding mechanism, and so she is embedding her dissertation in this project. So for this study, there's still a large need to improve cervical cancer screening implementation. What's nice about SIA is that it offers solutions that are within the healthcare system to improve processes and efficiencies. And it's not that our study staff are coming in to conduct the screening, but rather that the clinics and systems are working to help make changes, which it has implications for sustainability when the study ends. So the last study I want to present is also on behalf of Jess Long, and this was her postdoc fellowship, and it's called the FSB study, and this was in particular in close collaboration with Coast General Teaching and Research Hospital. So I'm presenting on behalf of them. So globally, so it's a little bit shifting. So globally, there have been improvements in maternal and under 5 mortality, but there has been little improvement made in stillbirths. So stillbirth rate in Kenya is 19, almost 20 per 1,000 births. This study is focused on fresh stillbirths, or FSBs, and they are defined as death of a fetus during labor or delivery. And so the focus was trying to see if we could decrease FSBs. So this is focused at Coast General Teaching and Referral Hospital, the labor and delivery ward. This in particular, we were asked by the Mombasa County Chief Officer of Public Health to assist in addressing the stillbirth rate in Mombasa. This is a CGTRH is a very high volume center, over 9,000 births a year, and their fresh stillbirth rate is 21 per 1,000. So this study aimed to understand the factors associated with fresh stillbirth at Coast General and to determine if an audit and feedback intervention can reduce fresh stillbirths, and to determine the cost of the audit and feedback intervention. So the purpose of this study was to try and reduce the rate of fresh stillbirths through small changes to care delivery. The labor and delivery ward staff are the ones who know best what barriers they face. And this study collected data to assess outcomes in the ward over time and kind of provided a structured method to try to make small changes to workflow and to improve outcomes. And all the changes were decided by the labor and delivery ward staff with guidance kind of from our study staff. So there's 2 main activities. One is this audit and feedback intervention, and the other are the Plan, Do, Study, Act cycles. So audit and feedback aims to assess the clinical outcomes in a healthcare system. So collecting that data, delivering structured feedback based off of these findings back to where the data is being delivered or where it's coming from, and then repeatedly evaluating the process and improving outcomes. And then Plan, Do, Study, Act cycles are, as they sound, but you plan for a change, you make a small test of change or a micro intervention, you study the effect of the change, and then you decide if you're going to accept, adapt, or abandon. Some of this will sound familiar from SIA. And so together, this study was aimed to audit, so to track both the stillbirths and key indicators of stillbirths over time, to implement micro interventions every month to improve care delivery, so these PDSA cycles, and then provide monthly updates to the labor and delivery staff about how the changes impacted stillbirth and key indicators, so that feedback. So our team learned that from interviews with staff that these are kind of the key indicators of care. So staff face many delays in getting patients to the surgical theater for a cesarean section or C-section. The patient charting can be incomplete, particularly in the partograph page of the inpatient booklet, which has all of the information about obstetrics and delivery. And then based off of that, the primary indicators that they were targeting were the time from admission to decision to provide a C-section. So time from decision to performing the C-section to being taken to the theater. So that's decision to incision. And then the percentage of partograph pages that are filled out. So kind of that documentation. So you will hear more about these. So the data sources, there are 2 main data sources that are being used. And they were linked using a patient identification number. There's the MOH Register 406, which is this one here that looks similar kind of to the MOH 512, large paper booklet that provides summary of the data on labor and delivery ward patients. And then there's an inpatient record booklet, which is filled for each mother-baby pair with detailed information about her labor and delivery care. So our study staff collected monthly data from both the MOH registry and the inpatient booklet. And then they worked with the medical records team to compare the data we collected with their monthly totals. And then study data collection was focused on all births that required a C-section and all births that result in stillbirth. And so once a month, study staff visited with Coast General during their Friday CME meetings. During these meetings, the study staff worked with the staff to report changes in key indicators since the last meeting, evaluate the micro interventions that were put in place, and then put a new micro intervention in place for the preceding month. And then during the month, the labor and delivery staff were the ones who were enacting those micro interventions that they chose. and our study staff were abstracted medical data on the indicators. And so this was completed from January to September of 2022. There were 8 feedback meetings that occurred between research team and the Labor and Delivery Board. We abstracted data from almost 2,000 deliveries and iteratively checked in with the leadership for labor and delivery to improve the feedback reporting. So this is the total number of deliveries per month from January of 2022 to September. So you can see kind of very high volume center. This is the proportion of deliveries that are C-section. So there's a little bit of a change kind of near the end of the study, but kind of consistent, almost a third of deliveries that ended in C-section. And then this is looking at the proportion of deliveries that were fresh stillbirths. So starting in January, following down to September, and you can see the trend line, and that these are raw data, but you can see the trend that it does appear that there is a decrease in fresh stillbirths over the time of this study. Similarly, one of our other indicators was whether the partograph was filled. And so you can see a general trend from the beginning to the end of this study that suggests that more of the partographs were filled. And then our other indication was admission to decision. So that time from admission to decision to have a C-section, you can see generally that line suggesting that there's a downward trend so that decisions were made sooner. Which is hopefully to another indicator to try and decrease fresh stillbirths. And then next, our other indicators. So once the decision was made to proceed with the C-section, how long did it take to go to actually have an incision, like the first incision? And you can see that again, it seems like there is a downward trend. So less time was taken once the decision was made to when incision happened. So our kind of prelim data suggests that our intervention and our implementation strategy had promise. We've continued to collect data up until March of 2023 to see what happens after the intervention ended. The formal analyses of these data that I just presented are in progress, but looking at like an interrupted time series analysis. And then also in-depth interviews during the intervention and post-intervention were conducted to supplement the quantitative results. And just briefly there, some of the main themes that came up were that staffing was a challenge in service delivery, as we can imagine, that staff know that there are guidelines for delivery of care, and that there are communication challenges that are communication channels that are present, but there are delays in time for cesarean, but that generally the audit and feedback and kind of PDSA cycles, that intervention was feasible and acceptable. So conclusions from the FSB study. So there's modest improvements were observed in both key indicators and in stillbirth. And the audit portion of the study required significant study staff time and may impact the feasibility and cost effectiveness of the method. But that interview data will provide more insight into how the study impacted staff behavior and if they felt the intervention was effective. And so finally, so talking about kind of future implementation research. So I presented on CCS SIA. My hope is to eventually scale this up as part of a PO1, kind of focusing on the whole cervical cancer care cascade in Kenya. So working on making collaborations across institutions to try and continue to improve care. Scott and I recently have been having meetings along with George Wanje to look at and kind of expanding on a project called Heated, which was a career development award by Adam Aloisio out of Brown that took place at Kenyatta National Hospital. And this is trying to improve HIV counseling and testing in accident and emergency departments. And so there's some prelim data that suggests that this program did help increase HTS in the accident and emergency at Kenyatta National Hospital. And now our hope is to try and scale up Heated, but using SIA to kind of support iterative improvements, but in moving it to accident and emergency departments on the coast of Kenya. So George and Martha are trying to get some prelim data from A&E departments on the coast to support this. And then also plans to scale up the FSV study now that we have some preliminary data that suggested it worked. So I have spoken quickly, but on behalf of kind of all of the Pwani Research Center, which we recently rebranded, and this is one of our logos, and all of our staff there, as well as our collaborators at the Mombasa County Department of Health, University of Nairobi, KNH, and Coast General Hospital, and all of our collaborators here.